stimulant. And you can see that that is a larger trial in young adolescents and adults that should be completing soon, hopefully. And the next line is a stimulant versus a non-stimulant, methylphenidate versus atomoxetine in children and adolescents. And the last one there, the head-to-head trials, is atomoxetine versus guanfacine in children and adolescents. The last three rows on this slide are newer treatments compared with placebo. So the XR-MPH in this case is Adhansia, which was approved in 2019, and then the Valoxine versus placebo in the other two trials. I'll just highlight that the very last row on this slide here, the Valoxine versus placebo, is actually being conducted in preschool age children. Next slide, please. So we'll move on to slide 66 and just kind of wrap up here with the summary of the findings. So we found 70 RCTs. Of the 70 RCTs, 26 were published since January of 2015. 15 of these were head-to-head RCTs, and 11 were placebo-controlled trials of 3 of the newer drugs, Adhansia, Journey, PM, both stimulants, and Qelbree, the non-stimulant. Most of the studies did enroll male children diagnosed with the combined presentation of ADHD and who were identified as white. Overall, all participants who received an active treatment had reduced symptom response, excuse me, compared to the baseline. As expected, adverse events are very common in these drugs, but the serious adverse events and discontinuations due to AEs were thankfully rare. Few studies actually reported on performance, quality of life, or medication adherence. And I just want to remind you that in terms of academic performance and even some of the symptom response outcomes, there were discrepancies between either like a clinician or teacher rating of the effectiveness compared to the parent or self-rated effectiveness and for their symptom response or performance. Next slide, please. So there are a number of limitations to this body of evidence. So the AAP recommends at least 6 weeks of treatment because of the titration needed to identify an optimal dose and to determine how effective that treatment is. So many of these studies had much shorter treatment periods, may have titrated the doses rapidly, or did titrate across a number of weeks, but then only provided 1 to 2 weeks of optimal treatment. Studies often exclude comorbidities, despite them being very common in this population, as Andrea addressed at the start of this talk. So there are common comorbidities like depression or anxiety, and these were only allowed to be individuals with these comorbidities were only allowed to be part of the trial if they had mild symptoms and were not being treated for those symptoms. Performance was often measured during a single day. These were the workplace and classroom simulated classroom and workplace environments. So they were followed by short treatment periods. They were followed after a short treatment period of usually no more than 4 to 10 days, and no washout periods because these were often the crossover trials. Next slide, please. So what about all of these new drugs? As you recall, we have 13 newly approved FDA drugs for ADHD these have all been approved since January of 2015. So most of the studies did not report a brand name drug. In terms of those that did, we are aware that of 4 of the newer drugs that were approved did appear in these trials, and they were generally compared with placebo. So there was, for the 12 new stimulants, we had the Mideas, the extended release methamphetamine salts, compared to an immediate release in 2 crossover trials, where the crossover trial with adolescents found that the extended release, so Mideas, performed better than the immediate release, but this was not the case with in adults, where there was no difference found. The other 2 drugs, stimulants that were included here, new stimulants, were Adhamsia and Journey PM, which were both compared to placebo and found that the active drugs were better than placebo. And similarly with the single new non-stimulant drug, Qelbree, compared with placebo. Next slide, please. So I just want to revisit the disparities that Andrea discussed in the introduction here. So that despite the knowledge that there is a disparity in diagnosis and treatment, most studies continue to enroll a majority of male children identified as white. While the diagnosis and treatment gap is closing for females of any age, studies still aren't enrolling this population, particularly the older females. And older females tend to be diagnosed in adulthood. I believe Andrea mentioned this, that it's common to be diagnosed from age 25 upwards if you're female. Studies also were rarely conducted in adults, despite this increase in diagnosis, that there are 2 ongoing trials that are looking at adult populations. And as Andrea mentioned at the introduction, that adult diagnoses are actually outpacing those in children and adolescents now. Psychosocial treatment is recommended alongside medication, particularly in children and adolescents. And evidence suggests that the medication assists with the symptoms, but generally not with quality of life or performance outcomes. The psychosocial interventions tend to help an individual learn skills to manage their condition, such as study skills, time management, or organizational skills. There's a growing evidence suggests that the biases that we're seeing between clinician and teacher evaluations of symptom response or performance compared to those of the parents or the individual themselves do lie across racial, cultural, and gender lines. Next slide, please. So just wrap up here with a couple of things to consider. There are some limitations with the instruments that are being used to determine whether treatments are effective. So for example, the ADHD and most of these other scales have been developed and validated in white male children. There are also behavioral expectations that are maybe applied to gender, race, or cultures that may differ. So these instruments may not be useful in determining that. So for example, there may be a behavior that's considered okay in boys, such as being outspoken and opinionated in the classroom, but this is not the case for girls. So that's a gender bias. There's also similar biases along racial and ethnic lines. It's common for individuals to try multiple medications at different doses to find one that balances the treatment response and the adverse events. So there's a lot of churn here, as you are probably aware. And there's also changes over an individual's lifetime. So they may need different treatments or different levels of treatment depending on where they are during a particular point in their life, if they're changing from adolescence to adulthood, if they're experiencing different kinds of stress or social supports are reduced or not, they may require different levels of treatment. And then slide 71 is the last slide here. So prior authorization policies are really common with these treatments, particularly those that are stimulant treatments. So things to consider, are those prior authorization policies aligning with current guidelines? So for example, offering both medication and psychosocial supports and allowing for that churn. Can a patient change their medications So if it becomes no longer effective or they develop a serious side effect, how easy is it for a patient to change the medications, or if they're experiencing life circumstances that require them to have a different kind of medication or a different level of medication? And lastly, what about how it allows an individual to engage and continue their treatment? If they have to get prior authorization to change the dose, does this mean that they may have a break in treatment and then maybe fall out of treatment completely? And this is especially concerning for those who live rurally or who identify as non-white, where it's common to see disconnect between engagement and continuity. And that is that for me. So I'll turn it back over to you for any questions or follow-up.
So yeah, if we have some questions, then go ahead and let us know, but we'll go ahead and get ready for our stakeholder input as well. And so first up is Lance Lewis of Corium.
Okay, hi everybody. Can you see me, hear me okay?
We can hear you.
Okay, all right. Okay, sounds good. Well, thank you, everybody. My name is Lance Lewis, and I'm the Field Medical Affairs Director with Corium. And today I will be presenting on the new ADHD treatment, Astaris. And I would like to focus my presentation today on 3 key areas. First, the unique characteristics of Astaris. Second, the duration of action and efficacy of Astaris. And third, important safety information. So let's start with the unique characteristics of Astaris. So Astaris is a CNS stimulant approved in March 2021, for the treatment of ADHD in patients 6 years of age and older, including adults. Astaris is available in 3 dosage strengths, equivalent to 20, 30, and 40 milligrams total dexmethylphenidate. Astaris comes in a capsule form and is administered orally once daily in the morning with or without food, and can be taken whole or consumed by sprinkling contents into 50 milliliters of water or 2 tablespoons of applesauce. And this is important for patients who have difficulty swallowing capsules. Each Astaris capsule contains 2 active ingredients in the following ratio: 30% dexmethylphenidate plus 70% surdexmethylphenidate, which is the first and only methylphenidate prodrug and only the second prodrug in the ADHD space. Surdexmethylphenidate is a new molecular entity and classified as a Schedule 4 controlled substance. However, Astaris itself is classified as a Schedule 2 controlled substance as it contains 30% dexmethylphenidate, which is a Schedule 2. Surdexmethylphenidate produces lower drug-liking effects compared to other Schedule 2 and Schedule 4 controlled substances in human abuse studies. In fact, it was these studies that led to the Schedule 4 designation for surdexmethylphenidate. So next, I'd like to share some information regarding duration of action and efficacy of Astaris. With many ADHD treatments, there remain vulnerable periods of time with inadequate drug coverage, either in the morning or early evening hours of the day. And so Astaris' unique co-formulation is designed to provide both early onset within 30 minutes and extended duration up to 13 hours. Astaris demonstrated a significant improvement in attention and behavior of children ages 6 to 12 years old, as measured by SCAMP-C scores in a laboratory classroom setting over a 13-hour period during the phase 3 trial. So finally, I'd like to share important information regarding safety. So Astaris has demonstrated a safety profile consistent with that observed for other methylphenidate products, and Astaris had no notable safety signals identified. The most common adverse events during the double-blind treatment phase of the phase 3 study were upper respiratory tract infection, headache, and abdominal pain. No adverse events were considered serious. In a long-term 12-month open-label safety study, Astaris did not have a clinically significant impact on height and weight, nor did it negatively impact sleep. Of course, these are always concerns associated with stimulants. For full prescribing and safety information, please refer to the Astaris package insert, which can be found at astaris.com. I would like to thank the committee for their time, and I'd be happy to answer any questions you may have. Thank you again.
Thank you. Next up we have is Patrick Harvey from Supernus Pharmaceuticals.
Here we go.
All right, we can hear you.
Okay, thank you. Good afternoon. My name is Patrick Harvey with Supernus Pharmaceutical Medical Affairs. Thank you for the opportunity to make a few comments regarding Qelbree. I would refer you to our complete prescribing information for full product details, including our black box warning in regards to suicidal thoughts and behaviors. As Andrea noted, there are over 31 drugs approved for the treatment of ADHD, but all but 3 of them are formulations of just 2 stimulant molecules, either methylphenidate or amphetamine. The diagnosis of ADHD in children is complex, and patients require more than just new stimulant delivery systems. Moreover, of the 3 FDA non-scheduled options, 2 of these have similar mechanism of actions, and physicians have indicated that there is a real need for additional non-scheduled options. Whether for consideration of stimulant abuse and diversion, or patient intolerance to stimulants or non-stimulants, or inability to swallow pills, Qelbree offers an important option for the treatment of ADHD. Qelbree is a new chemical entity and the first new molecular entity approved for ADHD in over 18 years. It's non-scheduled, once-a-day medication that can be taken any time of the day, and it was approved by the FDA in April of last year. The mechanism of action of viloxazine in the treatment of ADHD is unclear. However, it is thought to be through inhibiting the reuptake of norepinephrine. We have additional data from animal studies and models, and in vitro research suggests that viloxazine increases dopamine, norepinephrine, but also serotonin in the prefrontal cortex. This increase in serotonin is not through reuptake inhibition, but through direct action on receptors. This combined pharmacology makes viloxazine distinct from any FDA medicine used to treat ADHD. Additional clinical data that indirectly highlights areas unique to Qelbree that differentiates it from another NRI like Strattera is we have no evidence of hepatic injury as evidenced by minimal AST and ALT elevations and liver enzymes across all trials. Qelbree has multiple metabolic routes of elimination, is unlikely to have any interaction with other drugs metabolized by CYP2D6. And phenotypic CYP2D6 metabolizer status appears to have only minimal impact on Qelbree metabolism, with only a 1.5-fold increase from the poor metabolizers versus the extensive metabolizers. Qelbree is contraindicated with MAOIs and sensitive CYP1A2 substrates or CYP1A2 substrates with narrow therapeutic range, including theophylline. Qelbree has minimal impact on cardiovascular system with supratherapeutic dosing, seeing no clinically significant effects on cardiac polarization or other ECG parameters in healthy adults, suggesting it is not associated with a risk for cardiac arrhythmias. Medication adherence can also be negatively impacted due to pill swallowing difficulties, and Qelbree is the only non-stimulant that is designed to be swallowed whole, or the capsule can be opened and sprinkled on a small amount of food. So we ask that it be added to the preferred drug list, and I'll be happy to answer questions you might have.
Thank you. So we are open for questions. Lita, did you see anybody else who wanted to present as a stakeholder?
This is Lita Vasquez. I don't see any other hands raised.
Okay, with that then we should be able to look at our motion.
Hi, this is Laura Bestie. I just had a question for Pat Harvey regarding the viloxazine. Did you know, did they look at studying it in conjunction with the stimulants?
Yes, we just are finishing up a study with adjunctive therapy with stimulants.
Okay.
Yeah, it was a small study, but yes, we are doing it.
Lita, I'm wondering if you might be able to adjust it so we can see a little bit more of the motion.
Can you still read it at that size? Let's see if I can go in between here.
Anyways, it takes a little bit for it to update on my screen, so I can't tell you've changed it yet.
Oh,
This is Jenny. I'm just curious. I think the very top block is what I can't see. Are we only is velocity?
I would just to scroll down to the
Oh, sorry.
yes motion, but yeah,
Okay.
there are 2 new drugs here.
Thank you. I can see it now.
Perfect. Yeah, that's much better for me. Thank you.
This is Jenny. I might suggest that we start crafting the motion by copying the statement used last time regarding amphetamines, that both are short and long acting be covered. So yes, Lita, all the way down to, yep.
Just the top paragraph first?
Start there.
Okay.
Yeah. Again, this is Jenny again. I'm curious, and I'd like to hear from the other committee members. I can't see the words, but for the next section regarding non-stimulants, there it is. I don't know that there's anything convincing at this point in time to say that there would be reason to move to viloxazine. Is it viloxazine as a prior to trying atomoxetine? So I don't know. Maybe Lita, if you could cut and paste that second paragraph and put it up at the top so we could see it, and then the expert wordsmithers could help me. It would seem to me that in clinical practice, I don't know that I would go to viloxazine at this point in time prior to trying and failing atomoxetine. So if we might want to consider that as, or maybe we don't need to specify if it's on prior auth. Do we, maybe Donna, is that, or is there somebody from HCA that can answer that question? Do we need to list, as we have the non-stimulant atomoxetine listed by name as safe and efficacious and should be included as a preferred drug, but we have 4 non-stimulants. I can't remember if there's a reason why we have atomoxetine listed directly.
I have a feeling we haven't reviewed this class in a long time, and that
2019.
Yeah.
Okay.
So this is Laura Bestie. I do have some experience with this class of medications pretty extensively. And if you have a patient that would need a non-stimulant because of drug issues or drug use issues, you would want some of these non-stimulants as an option, especially in the teenage population with high schoolers or patients that are at risk for drug abuse. There would also be with viloxazine, you might have somebody that had depression as a coexisting disease state where there might be some benefit. I don't know if there's studies on that per se, because I haven't looked into that one as much, but that might also be a reason why you might choose that over another agent if you were considering that. I haven't looked specifically at that, so I don't know. So there might be a reason to keep that as an option for those patients.
I would agree that it should be an option. I think at this point, the data that I've read is that atomoxetine and viloxazine, excuse me, are looking quite similar in terms of efficacy. So I don't think we'd lose any access to an agent, to an effective agent for people who need both antidepressant and anxiety effects and attention benefits. I just wanted to be sure that we wouldn't miss an effective generic agent such as atomoxetine. You know, I wouldn't want to bypass that and go directly to viloxazine at this point in time. That's really what I want to be sure that we reflect.
So you were
This
saying
is Amy from the Healthcare Authority.
removing the, oh, sorry, go ahead.
You had called out atomoxetine previously, so that there was a non-stimulant that had to be a preferred drug, so that there was an option to have something that wasn't a stimulant. If you want that not to be atomoxetine, or if you want to have some flexibility there, you could say just make something along the lines of making a non-stimulant. There must be one preferred non-stimulant. Or you can call it out specifically, but that is why atomoxetine is called out there.
Thank you for reminding me of that. I remember that now.
You're welcome.
This is Jordan Starhawk. I think clonidine and guanfacine, you know, I think we'd be disappointed if those were the only non-stimulants available. And so I think that there's probably, I mean, I'm assuming this with the cost, but we'd probably be satisfied with atomoxetine and viloxazine being on the list. As long as one of those two, I think we'd probably all be satisfied. But I'm guessing with cost, it'd be atomoxetine would be the one that would make the list.
I would support that, Jordan.
So, you know, what you could, this is Donna, what you could say is that there should be one non-stimulant that is not an alpha agonist preferred on the list.
Yes, I like that.
And Lita, you can maybe say at least one, and that way it doesn't make it look like we can only have one. There you go. Thanks.
Do we need to retain the language that it's an alpha, not an alpha agonist that is safe and efficacious?
This is Jenny. I think that would be wise.
And do you want to then add, this is Donna, for treatment of ADHD, because there's safe and efficacious for what?
Yes, for treatment for ADHD, with the question, that wouldn't limit use of the alpha agonist for off-label treatment for anxiety or PTSD, would it? Into trouble. I mean, I know we're not talking about treatment of those conditions right now, so.
We don't have them on, I don't think anybody has those on prior auth because they're generic, and the extended release ones maybe, but I doubt it, because I think they're all generic as well.
Then I would say leave it at ADHD. I just wanted to be sure we weren't doing any unseen limiting of using it for other categories, using those others for other categories.
Mm-hmm. We're not, no.
I'm good. Okay.
Also, this is Laura Bestie. Can we move the bupropion down to the non-stimulant section?
I'm wondering if that's, is that grayed out because it's off-label?
Probably, but it should be under non-stimulants, not stimulants, correct?
Yeah, it's an antidepressant. I don't, yeah.
You want to look at the last paragraph?
Or should it just be listed like other medications rather than just other stimulants, other medications or off-label medications?
I would just going to suggest that, Laura. I would agree. Just change the title. Yeah, just change the title of the of that.
Complete.
What did you settle on?
Off-label treatments.
Then it looks like we probably just need to include that last paragraph as well.
This is Ginny. I don't want to put Laura on the spot, but if you want to make your first motion, I want to welcome you into the fray. If there's nobody else that has any other comments, otherwise, okay. If you're not ready, it's good.
I can do this. Okay, I need to see the top there, so I just read the whole. Okay, so this is Laura Bestie, and after considering the evidence of safety, efficacy in special populations for the treatment of attention deficit hyperactivity disorder, I move that methylphenidate-based and amphetamine-based agents of both long and short-acting formulations are safe and efficacious. A long and short-acting formulation of each stimulant should be preferred drugs on the Washington State Preferred Drug List. No single stimulant medication is associated with fewer adverse events in special populations. The stimulants listed above shall not be subject to therapeutic interchange on the Washington Preferred Drug List. After considering the evidence of safety, efficacy in special populations for the treatment of attention deficit hyperactivity disorder, I move that at least one non-stimulant that is not an alpha agonist that is safe and efficacious for ADHD should be included as a preferred drug on Washington State Preferred Drug List. After considering the evidence of efficacy in special populations for this treatment of attention deficit hyperactivity disorder, I move that the alpha agonists clonidine and guanfacine are safe and efficacious, and that both of these agents should be included as a preferred drug on the Washington State Preferred Drug List. I so motion to accept.
Perfect. Thank you, Laura. Do we have a second?
This is John McKay. I'll second that.
Good. We're getting our new ones all participating. All in favor, please say aye.
Aye.
Any opposed? All right. Thank you. So with that, then I guess the work of the Pharmacy and Therapeutics Committee is all done, and we will adjourn and then reconvene as the Drug Utilization Review Board. And then the first item on the agenda for that is dealing with some antibiotics and a presentation from Umang.
Okay, and Marissa, are you going to present now?
Hi, this is Marissa. Yes, I'll go ahead and present.
All right, perfect. Jordan, can I ask you just to confirm whether or not you can hear me?
You're a little quiet to me, but I can hear you.
Yeah, same to me. You sound pretty quiet.
Okay, is that better by any chance?
Still a little quiet.
It's the same.
Okay, I apologize. I guess having some issues here. I'll do my best to speak up. Is that better by any chance for everyone?
It's a little bit.
I know there's a break coming up during there. I'll go ahead and try to make sure that this gets fixed.
Sounds good. All right. Thank you.
Okay. Alrighty. So then we'll be reviewing the first subclass will be antibiotics. For just a reminder for the committee, and some of the new members, what we tend to do is we look at new clinical updates within the last 13 months or so. If there are any relevant significant clinical updates, I usually present those. If there are no updates and guidelines, things like that, I usually try to keep them in the appendices or they're available in the TCRs for the committee's access there as well. And so on the next slide, we'll be going over antibiotics and respiratory agents. Now, some of the new members may wonder why some of these are broken down the way they are. Magellan has specific clinical updates, has specific therapeutic classes in the subgroups that may be different from Apple Health. And so I do my best to kind of show what our title is for some of these classes, and if they're broken out, what the Apple Health classes are. So for antibiotics, we'll be going over inhaled aminoglycosides, inhaled monobactams, along with cystic fibrosis agents and CFTR potentiators.
This is Marissa. Sorry to interrupt. I just wanted to make a note to the DUR board that there was an oversight on my end. So the slides that you saw online or that you received did not have the CFTR potentiators drug class listed. We did have a recent change to the cystic fibrosis class where we split out some of the cystic fibrosis agents versus having the CFTR potentiators separate. So just wanted to note that change, and I have made that change also to the motions as well. So that is taken into account. I just wanted to let you guys know. So sorry, Umang, to interrupt. You can go ahead and proceed.
No problem at all. Thank you. Okay, so we'll go on to the next slide. Just a little bit of background like we normally do. So cystic fibrosis is a serious autosomal recessive multi-organ disorder. It affects about 32,000 children and adults in the United States, and it's the most common fatal genetic disease in Caucasians. The median survival in patients is about 49 years, with 80% of patients reaching adulthood. Children are anticipated to live up to approximately 40 years of age with current treatments. And in 2019, adults comprised approximately 56% of the cystic fibrosis population, while in 1989, they comprised approximately 31%. Mutations lead to the disease of the exocrine gland function, and so it results in the formation of a thick mucus that builds up in the lungs, the digestive tract, and other parts of the body. The cystic fibrosis transmembrane conductance regulator, or CFTR, functions as a chloride channel, and the mutations result in abnormalities of the chloride transport across the epithelial cells on the mucosal surfaces. Goals of treatment include maintaining lung function by controlling infection and clearing mucus, maintaining appropriate growth by providing nutritional support, and managing disease complications. On the next slide here, as I mentioned, the goals are threefold: controlling infection, clearing mucus in the airway, and providing nutritional support. And then the CFTR modulators are the newest class of medications available for the disease and improve the chloride ion transport abnormalities. As I mentioned earlier, the guidelines are, as you can see, about 7 to 8 years old. And so they are here for the committee's review and again in the TCR, but we won't be going over them, just here for completeness sake. On the next slide, we'll go over drug-specific updates. So and again, for some of the newer members, when you see bolded information here, the bold indicates the new clinical update. If there was a new indication, an expanded formulation, a new black box warning, or so on and so forth, I tend to just kind of highlight and draw focus to the update, and we won't be going over all the clinical information as not all of it was updated. So in December 2020, the FDA approved Kalydeco for the treatment of cystic fibrosis in patients 4 to less than 6 months of age and weighing 5 kilograms or more who have one or more mutation in the CFTR gene that is responsive to ivacaftor based on clinical and/or in vitro assay data. Previously, this was only in patients greater than six months or older. Again, no update to the indication aside from expanding the age. The dosage obviously has been updated to include pediatric patients 4 months to less than 6 months of age and less than 5 kilograms. And the dosing, as you can see, is 125 milligram packet mixed with 1 teaspoon of soft food or liquid, administered Q12 hours with fat-containing food. No changes in availability here as well. And just some information for the committee in terms of special populations. It is a category, pregnancy category B is in beta. There is a hepatic dose adjustment, and there is no renal dose adjustment recommended for mild to moderate renal impairment, and there are no studies for moderate to severe renal impairment here. On the next slide here, we have Trikafta. A few updates in 2020 and 2021 for this medication. In December 2020, the PI updated to expand the indication to include patients with cystic fibrosis who have a mutation in the CFTR gene that is responsive based on in vitro data, updated indication for treatment of cystic fibrosis in patients aged 12 years of age or older who have one or more F508del mutation in the CFTR gene, or a mutation in the CFTR gene that is responsive based on in vitro data. In June 2021, FDA approved this medication for patients 6 years of age through 11 years of age, again with the same F508del mutation. And in June 2021, they also approved a new dosage of the subgroup. So we have 50 milligrams of elexacaftor, 25 milligrams of tezacaftor, and 37.5 milligrams of ivacaftor, co-packaged with ivacaftor 75 milligrams to accommodate the new dosing and the new age group. As you can imagine, the dosage is very weight and age specific. So it's stratified, again, by age and weight that can be found in the TCR and the PI. The availability hasn't really changed. We just now have an additional lower dose co-packaged formulation available as well. And on the last slide here, we have some deco. And in December 2020, PI updated to expand the indication for patient populations to include additional mutations in the CFTR gene that have been identified as responsive based upon in vitro data. So I'll go ahead and pause there for the committee.
Hi, this is Marissa. I'm just going to go ahead and bring up the publication as well. So to our new DUR board members, this is just the AHPDL is pretty big. It's over 500 classes. So for your guys' reference for these meetings, we just give you a snapshot of the classes that we are reviewing for that are relevant to the meeting. So this is just the ones that we're reviewing today. So the particular classes of interest that I would want to point out are starting out on line 4 and line 11, which are antibiotics. And you can see which products we have preferred, which would be marked with a P, and N is non-preferred on our PDL. So I'll go ahead and pause for about 30 seconds for you to see which products we have. You should also have received a copy of this as well. And then, like I mentioned earlier before, I did not include the CFTR potentiators as an oversight, which I apologize again. So we have updated this. This is the updated PDL, but you can see here that we have the respiratory agents, cystic fibrosis agents, which starts on line 175, and then our CFTR potentiators start on 178. And you can also see which products we have preferred and non-preferred in both of those classes. And I can move to the motion, Jordan, whenever you're ready, or if you have any questions about the AHPDL.
We do have a couple of stakeholders for this too, so maybe that's where we should.
Oh, yes.
Next, I think. So first is Lisa Cambridge of Perry Respiratory. I don't know if we have Lisa there or not. It's probably, let's see.
This is Lita. I'm wondering, is Lisa Allen the correct Lisa? I'm gonna unmute Lisa Allen. Please let us know if you are Lisa Cambridge. Oh, if you could unmute yourself.
Hi, I am not Lisa Cambridge. I am Lisa Allen with Vertex Pharmaceuticals.
Well,
I don't see Lisa Cambridge on here.
All right, let's go. We'll keep on looking. Let's go next to Kristen Dandurand.
Okay, and Lisa, are you wanting to speak on this topic? Lisa Allen? Sorry, you're muted again.
Yes, please, at the appropriate time. Thank you.
Okay. Well, why don't we have Lisa Allen go since she's on? Okay.
That is me, Lisa Allen. Please, you have 3 minutes.
Thank you very much. Good afternoon. Again, my name is Lisa Allen with Medical Affairs at Vertex Pharmaceuticals. Thank you for the opportunity to provide public testimony on behalf of Vertex's cystic fibrosis transmembrane conductance regulator modulators. CFTR modulators are the only cystic fibrosis medicines that work by targeting the underlying cause of CF, which is a defect in the CFTR protein. And as Dr. Patel nicely reviewed, there are 4 CFTR modulators approved for the treatment of CF based on age and genotype, including Trikafta, Symdeko, Orkambi, and Kalydeco. I'm not going to belabor the ladle updates that have occurred since he covered those so thoroughly, but I would like to add that on October 4th of last year, Section 6.2, the post-marketing experience, was added to the Trikafta USPI, and Section 5.1, warnings and precautions, was updated as follows. Liver failure leading to transplantation has been reported in a patient with cirrhosis and portal hypertension while receiving Trikafta. Avoid the use of Trikafta in patients with pre-existing advanced liver disease unless the benefits are expected to outweigh the risks. If used in these patients, they should be closely monitored after the initiation of treatment. Isolated elevations of transaminases or bilirubin have been observed in patients with CF treated with Trikafta. In some instances, transaminase elevations have been associated with concomitant elevations in total bilirubin and/or the International Normalized Ratio, or INR, and have resulted in patients being hospitalized for intervention, including in patients without a history of pre-existing liver disease. Please refer to the full prescribing information for a complete list of warnings and precautions associated with each modulator, as well as additional safety data. Thank you for your time. And I would like to add just one correction that I noticed in the Magellan report. When it's discussing the ivacaftor dosing for the newest age group, the 4 to less than 6 months old, it should say greater than 5 kilograms, not less than 5 kilograms. Thank you. Any other questions? I'm happy to answer them.
Thank you, Lisa. Then we'll be moving then to Kristen Dandurand of GC USA.
Can you hear me okay?
We can, Kristen. Yeah, go ahead.
Thank you for the opportunity to present. I'm going to present on Bronchitol. It's an mannitol inhalation powder for oral inhalation use. So, you know, as you mentioned just a few minutes ago, CF affects approximately 31,000 patients in the US, with the lung being the key organ affected. And despite the introduction of CFTR modulators, most patients still require mucoactive agents to target manifestations of lung disease. Roughly 70 to 90% of patients utilize mucoactive agents as part of their airway clearance regimen per the 2019 CFF registry report. And cleaning of the device, and a need for a power source for the nebulizer. So Bronchitol powder contains a sugar alcohol, D-mannitol. It's a spray dried into particles of respirable size. It's indicated as add-on maintenance therapy to improve pulmonary function in adult patients 18 years of age and older with cystic fibrosis. You use bronchitol only for adults who have passed a bronchitol tolerance test. And the dosing of bronchitol is 400 milligrams. It's 10 capsules twice a day. By oral inhalation, it's administered via portable breath-actuated dry powder inhaler. The doses are taken in the morning and evening, with the later dose taken about 2 to 3 hours before bedtime. Prior to the prescribing of bronchitol, the BTT or the bronchitol tolerance test must be administered and performed under the supervision of a healthcare practitioner who's able to manage acute bronchospasm or identify patients who are suitable candidates for the bronchitol maintenance therapy. Contraindications are hypersensitivity to mannitol and failure to pass the BTT. The efficacy of bronchitol for the treatment of CF was evaluated in 3 26-week randomized double-blinded controlled studies in patients with CF. In the event of, since time is running out pretty quick, I'm going to direct you to the package insert. This information is in there as well, but in trial 1, a statistically significant improvement in FEV1 of 51 milliliters was observed for bronchitol with 95% confidence interval 6 to 97 milliliters with p-value less than 0.05. In trial 2 and 3, the between group difference in FEV1 changed baseline was 68 milliliters, which is 95% confidence interval, 24 to 113 milliliters, and 52 milliliters, which was a 95% confidence interval, -3 to 107 milliliters. Post hoc descriptive analysis of the adult subgroups in trial 2 and 3 observed between group differences and adjusted mean FEV1 of 78 milliliters. I'll direct you again to the PI for the warnings and precautions. Adverse events, the most common adverse reaction of greater than 3% was observed in 761 patients across trials 1, 2, and 3 were cough, hemoptysis, oral pharyngeal pain, vomiting, bacterial sputum, identified pyrexia, and arthralgia. In conclusion, bronchitol is a dry powder inhaler formulation of mannitol using a breath-actuated inhaler. It's demonstrated a statistically significant improvement in FEV1 and CF303 pivotal trial with consistent pulmonary function improvement in adults across phase 3 studies. Maintenance of lung function in CF patients, key focus of their care, and with patients often using multiple inhaled agents as part of their airway clearance regimen.
All right, thank you, Kristen.
Thank you.
All right, I don't know that I see anybody else. Lita will confirm that for me, and then we can move on to the motion.
This is Lita. I don't see any other hands raised.
This is Marissa. Can you see the motion okay, Jordan?
I can now, yeah, thank you.
Okay, great. I think it's a little laggy.
Yeah.
This is Leah Marcotte. I move that all products and drug classes listed on slide 2 are considered safe and efficacious for their medically accepted indications and are eligible for the preferred status and grandfathering at the discretion of the HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Diane Schwelke, I second.
All in favor, please say aye.
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 Any opposed? All right, thank you. Next up for our topics is the anticoagulants, factor 10A and thrombin inhibitors. And back to you, Among, for the presentation.
Perfect, thank you. Alrighty, so the next will be anticoagulants, specifically factor 10A and thrombin inhibitors, just focusing on the oral medications for these. On the next slide here, perfect, there we go, thank you. So a little bit of background. First being venous thromboembolism. So VTE manifests as a deep vein thrombosis and a pulmonary embolism, and is a major consequence of various surgical procedures and medical conditions. DVT occurs when a thrombus composed of cellular material bound together with fibrin strands forms in the deep venous portions of the extremities, most commonly the legs. The exact number of patients impacted by DVT and PE is unknown. However, it's estimated that these conditions affect approximately between 300 and 600,000 people in the US every year. If left untreated, approximately a third of patients who develop a PE will die within the first few hours of the event. Generally, the risk of VTE increases with the number of risk factors present, major traumas, and age. Due to the risk of morbidity and fatal PE associated with DVT, prophylaxis has become the standard of care for patients at high risk thrombosis. And then CAD, or coronary artery disease, and PAD, peripheral artery disease, occurs in approximately 14 million Americans for CAD and 8.5 million over the age of 40 for PAD. Prevention and treatment of atherosclerosis focuses on modifiable risk factors. Therapy includes lifestyle changes and the medical treatment of hypertension, hyperlipidemia, and diabetes. Antiplatelet medications such as aspirin, clopidogrel, prasugrel, ticagrelor, or Vorpaxar are indicated for the reduction of thrombotic CV events in patients with established CAD or PAD. On the next slide, atrial fibrillation is a common arrhythmia ranging in prevalence of from 2% in patients under 65 of age to 9% for those 65 and older. The prevalence is higher in men than women, and it increases with age. And more than a third of patients with AFib are 80 years of age or older. Patients with AFib can have a reduction in cardiac output, resulting in pooling of blood in the heart, atrial thrombus formation, and potential systemic embolization. Ischemic stroke is the most frequent clinical manifestation of AFib-associated embolization, and it increases the risk of stroke 5-fold. In patients with AFib, the ACCP recommends measuring thromboembolism using the CHADS-2 VASC score, which considers risk factors such as gender, age, history of stroke, TIA, thromboembolism, as well as history of CHF, hypertension, diabetes, vascular disease, PAD, or aortic plaque. The score ranges from 0 to 9, with higher numbers indicating more risk. Guidelines for AFib were over a year, so they are in the appendix as well. On the next slide here, we have the AHA-ACC for the 2020 guidelines and the ACC 2020 guidelines as well. These were right on the cusp of being about a year, so I kept these in here to err on the side of caution. The AHA-ACC in 2020 published guidelines on the diagnosis and treatment of hypertrophic cardiomyopathy. Notable pharmacological recommendations include for symptomatic patients with left ventricular outflow tract obstruction, non-vasodilating beta blockers are recommended, but alternatives for select patients include verapamil, diltiazem, and disopyramide. For non-obstructive hypertrophic cardiomyopathy with preserved left ventricular ejection fraction, beta blockers, verapamil, diltiazem are recommended, and consideration of anticoagulants as the default treatment option for patients who also have AFib independent of their CHADS-2 VASC score. And additional guidance on the use of antiarrhythmic therapy and heart failure agents is included as well. The ACC published an expert consensus decision pathway on managing bleeding episodes in patients taking oral anticoagulants. It updated the 2017 decision pathway for peri-procedural management of anticoagulation in patients with non-valvular AFib. They provide guidance for temporary or permanent interruption of therapy, general approaches to bleeding management, decision support for treatment with a reversal agent, and indications and timing for reinstituting anticoagulant treatment. The panel does not recommend routine administration of platelets for patients on antiplatelet agents for major bleeding, and they do not recommend routine oral anticoagulant reversal for non-major bleeding, but clinicians may interrupt therapy until patient is clinically stable and hemostasis is achieved. On the next slide here, moving to drug specific, first we have Pradaxa. So in June 2021, FDA approved Pradaxa for the treatment of VTE and to reduce the risk of VTE in pediatric patients 3 months or older. Previously, it was only approved for these indications in adults. Additionally, they also approved a 20, 30, 40, 50, 110, and 150 milligram oral pellet pack for administration with select soft foods such as baby rice cereal, water, mashed carrots, bananas, applesauce, or apple juice. The oral pellets are indicated for the treatment of VTE and to reduce the risk of VTE in said pediatric patients 3 months to less than 12 years of age. As you can see, there are black box warnings with anticoagulants, specifically premature discontinuation leading to thrombotic events and possible epidural or spinal hematoma in patients who have been treated with Pradaxa and are receiving neuraxial anesthesia or undergoing spinal puncture. As you can see, the dosage here is stratified by age, and the availability was updated to include the oral pellets, as I mentioned, for the pediatric patients earlier. In terms of special populations, first, patients who are pregnant. There's insufficient data to determine a drug-associated risk in patients who are pregnant, and for patients with renal dysfunction, there has not been clinical studies completed for pediatric patients with a GFR less than 50. On the next and final slide for this subclass, we have Xarelto. In December 2021, the FDA approved a new oral suspension formulation, 1 milligram per milliliter once reconstituted. And additionally, in the same time, the FDA approved 2 new indications. One, the treatment of VTE and reduction in the risk of recurrent VTE in pediatric patients from birth to less than 18 years of age. And 2, for thromboprophylaxis in pediatric patients 2 years or older with congenital heart disease after the Fontan procedure. As you can see, Xarelto has a litany of other indications as well, but just highlighting the two updates there. Dosage, as you can imagine, are broken down by indication and age as well. And the availability, no changes aside from the new oral suspension as well. And due to space in that one, I just wanted a full transparency here. Due to space, I wasn't able to include some of the other information, such as black box warning, things like that. But please note that Xarelto also contains similar black box warnings to Pradaxa, specifically with premature discontinuation and spinal epidural hematoma. I'll go ahead and pause right there for the committee.
Hi, this is Marissa. I will go ahead and display the AHPDL. So the class that Umang just presented on will be on line 12 here, which is the factor 10A and thrombin inhibitors. So I'll go ahead and pause and let you take a look at what we have preferred and non-preferred on our AHPDL. And if we have any stakeholders and the motion, just whenever you're ready, Jordan.
Sure. We do have one stakeholder for this one. That is Piao Ching with Pfizer. So we can be ready at this time if you're ready to present.
Good afternoon. My name is Piao Ching, and I'm a pharmacist with Pfizer Medical Affairs. Thank you for allowing me to provide medical information on apixaban, brand name Eliquis. For more information beyond what I present today, please refer to the package insert for the product, or I can provide further information upon request. We are asking the committee to consider retaining Eliquis as a preferred option on the Apple Health PDL. We have presented the relevant information contained in the prescribing information to the committee before, so today I will provide new data published in December 2020. This is an independently non-industrial study funded by the FDA. Using the FDA Sentinel distributed database, a retrospective cohort analysis compared the rates of ischemic stroke, gastrointestinal or GI bleeding, and intracranial hemorrhage or ICH among adult NVAF patients 21 years and above, initiating apixaban or warfarin between December 2012 and June 2018. The use of one-to-one propensity score matching, or PSM, resulted in 55,038 apixaban warfarin match pairs. Subgroup analysis by age, 21 to 64 years old, 65 to 74 years old, and 75 years and above were also conducted. There are several limitations which include inability to include some data partners within the Sentinel system due to model convergence issues. Despite the use of a propensity score matching, or PSM, there is potential for residual confounding due to unobserved confounders. Also, the year of cohort entry was not included in the propensity score model, and so the effect of circular trends within each ICD era might not have been accounted for. The analysis only includes patients receiving apixaban 5 mg twice daily. In the overall population, apixaban use was associated with lower risk of ischemic stroke, GI bleeding, and ICH compared with warfarin. The same findings were observed in the 75 years and above age subgroup. In the 21 to 64 years age subgroup, apixaban use was associated with lower risk of ischemic stroke and GI bleeding, and a similar risk of ICH compared with warfarin. In the 65 to 75 years age subgroup, apixaban use was associated with similar risk of ischemic stroke and ICH, and a lower risk of GI bleeding compared to warfarin. With this in mind, we respectfully request that the committee consider retaining apixaban as a preferred option on the Apple Health Medicaid PDL. Thank you very much for your time and attention. I'll be happy to address any questions you may have.
Thank you. So if we have any questions, let us know. That's the only stakeholder that I had listed, and I don't see anybody with their hand raised right now. The next thing that we'll do is take a look at the motion.
Actually, this is Laura Bestie, and I did have a really quick question here. Oh, so this is only oral, so injectable medications would be reviewed separately, is that correct?
Hi, this is Marissa. So Laura, a lot of our injectable medications that we have, we either don't include them on the PDL. I would have to double check with our injectables. They might be an archived class that we've reviewed pretty quickly in the past, but that's typically kind of how we handle those injectable or IV medications. It may not be reviewed because it's not included on our PDL, or it's archived is usually the reason. But yes,
Okay.
It would be reviewed separately if it was on the PDL.
Okay, I just wanted to ensure that we weren't saying they couldn't be used or something by voting on this. So, okay, thank you.
No problem.
This is Kavita Chavla. I move that all products in the anticoagulants, factor Xa and thrombin inhibitors oral drug class are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only one product is preferred.
This is Laura Bestie. I second the motion.
All in favor, please say aye.
Aye.
Any opposed? All right, the motion passes. So we're scheduled for a break on the next thing at the agenda, but we are running a little behind. Do we want to take that 10-minute break and come back?
This is Lita. Yeah, I think it would be good to take a 10-minute break. So let's come back. It's, let's see, 3:11. So at 21 after, I'll put up a sign.
Or come
Or
back
after-
at 20. Take a 9-minute break. How's that?
Okay.
That sounds good to me.
All right, thanks.
Marissa, if you could put up a sign that we'll be back at 3:20. Oh, okay, I'll do it.
Sorry, I was trying to get myself off mute. I'll go ahead and do it.
All right, looks like it's time for us to get restarted again. Anti-diabetics is our next topic here, and Umang to start again for us. And thanks, Umang, for working on your volume. It's been a lot better.
Awesome.
For me, at least.
I'm glad to hear. Thank you. Next up, we'll move on to anti-diabetics. This will encompass both amylin analogs, SGLT2 inhibitors, DPP4 inhibitors, along with DPP4 and SGLT2 inhibitor combos, DPP4 and TZD combos, GLP-1s, and GLP-1 insulin combinations. Moving on to the next slide, it's estimated that over 34 million Americans have diabetes, of which 90 to 95% have type 2 diabetes, and it is responsible for increased morbidity and mortality. Adequate glycemic control is crucial to minimize chronic microvascular and macrovascular complications. Exogenous insulin supplements deficient levels of endogenous insulin and temporarily restores the ability of the body to properly utilize carbs, fats, and proteins. Multiple insulin proteins products are available and are used as replacement therapy and management of both type 1 and type 2 diabetic patients when glycemic goals are not met with oral anti-diabetic agents. In addition to exogenous insulin, there are several pathways by which blood glucose may be regulated in diabetic patients. The SGLT2 inhibitors reduce renal glucose reabsorption in the proximal convoluted tubules, leading to increased urinary glucose excretion. On the next slide here, moving over to guidelines. Again, these were close to that 1-year cutoff, so kept them in here to err on the side of caution. Additional guidelines are in the appendix. In 2020, the KDIGO guidelines came out for managing diabetes in patients with CKD. They recommend an individualized A1C target of less than 6.5% to less than 8% in diabetic patients with CKD, based on CKD severity, macrovascular complications, comorbidities, life expectancies, hypoglycemia awareness, and management resources, and hypoglycemic risk of medication. In addition to lifestyle therapy, KDIGO recommends first-line treatment with metformin and an SGLT2 inhibitor in most patients with a GFR of over 30 milliliters per minute. A GLP-1 agonist, generally preferred, DPP4 inhibitor, insulin, sulfonylurea, TZD, and or AGI may be added as needed for glycemic control. These additions are guided by patient preference, comorbidities, eGFR, and cost, and they advise against the use of GLP-1 and DPP4 inhibitor. The ACC guidelines in 2020 published an expert consensus decision pathway for CV risk reduction in patients with type 2 diabetes. They identify opportunities to initiate an SGLT2 inhibitor or GLP-1 agonist with demonstrated CV or renal benefit in patients with type 2 diabetes. A medication from either class may be initiated in any patient with type 2 diabetes and ASCVD at the time of diagnosis of type 2 diabetes or ASCVD, or any time after diagnosis, including at hospital discharge. An agent from either class can also be started in patients with type 2 diabetes without established ASCVD, but who are at high risk. In addition, initiation of an SGLT2 inhibitor with demonstrated CV or renal benefit is recommended in patients with heart failure and or diabetic kidney disease. A GLP-1 receptor agonist is an alternative in patients with a GFR less than 30. And then the American Gastroenterological Association came out with guidelines in 2021. They estimate that up to 70% of individuals with type 2 diabetes have non-alcoholic fatty liver disease. They inform that GLP-1, SGLT2 inhibitors, and pioglitazone can improve the cardiometabolic profile and reverse steatosis in patients with diabetes and non-alcoholic fatty liver disease. They recommend a GLP-1 or pioglitazone in patients with indeterminate or high-risk clinically significant liver fibrosis. SGLT2 inhibitors appear to provide benefit in patients with non-alcoholic steatohepatitis or NASH and associated comorbidities. And the guidelines advise to prescribe a GLP-1 or and SGLT2 inhibitor according to the ADA guidelines. On the next slide, the ADA guidelines came out with a little bit of an update in 2021. As you can see, there's a lot of information here. I'll kind of just go over the main clinical updates found in bold. In patients using ambulatory glucose profile, glucose management indicator to assess glycemia, a parallel goal is a time in range of over 70% with time below range of less than 4%. During pregnancy, the ADA recommends a target A1C of 6 to 6.5% to be reasonable, but can be adjusted based on hypoglycemia risk. More frequently, such as monthly A1C monitoring may be required. For diabetes technology, an automated insulin delivery system should be considered in adults with type 1 diabetes who have the skills to use the device in order to improve time in range and reduce A1C and hypoglycemia. These systems may also be useful to improve glycemia in children. Regarding obesity management, the guidelines state that locazepam should no longer be used as the FDA requested its market withdrawal. For type 2 diabetes pharmacologic therapy, the guidelines advise to interrupt SGLT2 inhibitor therapy before scheduled surgery to avoid diabetic ketoacidosis, and this aligns with the label revisions for the SGLT2 inhibitors. And for management of CVD in patients with type 2 diabetes, the ADA advises to consider an SGLT2 inhibitor in patients with heart failure with reduced ejection fraction to reduce the risk of worsening heart failure and CV death. On the next slide here, we'll move over to the drug-specific information. First, we have Farxiga. In May 2021, FDA approved a new indication to reduce the risk of sustained eGFR decline, end-stage kidney disease, CV death, and hospitalization for heart failure in adults with chronic kidney disease at risk of progression. As you can see, it has this medication has other indications, no changes in other indications, precautions, dosing, or formulations. Regarding specialized populations, safety and efficacy has not been established in pediatric patients. It is not recommended in women who are pregnant during their second or third trimester. In terms of hepatic impairment, there's no dose adjustment recommended for mild, moderate, or severe hepatic impairment. And GFR of less than 45 milliliters per minute is not recommended to use this medication. On the next and final slide, we have Bydureon and Bydureon BCise. And in July 2021, FDA approved this medication as an adjunct to diet and exercise to improve glycemic control in patients with type 2 diabetes, to include pediatric patients 10 years of age or older. Previously, it was only approved in adults. Again, similar to the previous slide, there are no other updates, no changes to the precautions, the black box warnings that are lined out in front of you, the dosing or formulations. In terms of special populations, it is not studied in patients with acute or chronic hepatic impairment, and it is not recommended in patients with a GFR of less than 45. Go ahead and pause there for the committee. Actually, Marissa, I apologize. I'm going to keep going right through the insulins.
Yeah, I was just going to let the DUR board know that we actually lumped all the anti-diabetics into one motion. So I'll just go ahead and have Umang do the rest of the clinical review, and then the motion will be at the very end.
Thank you. Sorry about that. I was so excited to get a sip of water that I forgot. I'll keep going. So we'll move right along to the anti-diabetic insulins. Here we have intermediate acting, long acting, pre-mixed, rapid acting, and short acting. On the next slide here, we have a medication, Semglee. In July 2021, the FDA approved Semglee as an interchangeable biosimilar to Lantus. It is a long-acting human insulin analog indicated to improve glycemic control in adults and pediatric patients with type 1 diabetes and in adults with type 2 diabetes, and it is not recommended for treating diabetic ketoacidosis. Everything here, as you will see with precautions, dosing, formulations, is identical to Lantus. For precautions, as the committee can imagine, with insulin, one of the precautions is hyperglycemia or hypoglycemia may occur with changes in insulin regimen. Hypokalemia can occur, and fluid retention and heart failure with concomitant TZD use. Dosing, as you imagine, for insulin is very individualized, and the formulations are an injection of a U100, so 100 units per milliliter, and they're available in 10 milliliter multiple dose vials and a 3 milliliter single patient use pre-filled syringe. And now on the next slide here, we have Resvogler. I apologize for my mispronunciation there, if I mispronounced it. In December 2021, the FDA approved the second biosimilar insulin to Lantus. It is a long-acting human insulin analog indicated to improve glycemic control in adults and pediatric patients with type 1 diabetes and type 2 diabetes and adults with type 2 diabetes. Again, to not, I guess, repeat myself here, you can see there's identical limitations of use, identical precautions, dosing is identical as it is individualized, and the formulations, it is available in a 3 milliliter single patient use prefilled syringe. We'll go ahead and pause here now for the committee.
Mom, I had a question for you. Is Bydureon available in the marketplace currently?
That is a great question. I'm gonna look into that to see if there's an active recall. Oh,
Hi, Umang. This is Donna. I think it's just the Bydureon B size, right? Is that correct? Is available?
That's from what I'm seeing from my wholesalers. I just noted that it was preferred as one of the GLP-1 agonists and not available in the current marketplace.
and Donna is correct. It is only Bydureon B size, not Bydureon.
So we can get that removed. This is Donna. We can get that removed from the PDL document.
Hi, this is Marissa. I'm sure you guys can see, here's all of the preferreds and non-preferreds for the anti-diabetics that Umang just reviewed. I'll try to go through them slowly. If you have any questions, please let me know.
We'll try to be scrolling through that, but we do have a couple of stakeholders as well. So first up is Mark Manival of Boehringer Ingelheim.
Awesome. Thank you very much. Can you hear me?
I can. Go ahead.
Awesome. Good afternoon, and thank you for giving me an opportunity to speak with you today. My name again is Mark Manival. I'm a Washington State-based pharmacist and health economics and outcomes research liaison for Boehringer Ingelheim. I'm pleased to provide you today with an update on our product line containing the SGLT2 inhibitor empagliflozin. Jardiance, Synjardy, Synjardy XR, Glyxambi, Trijardy XR are all indicated as adjuncts to diet and exercise to improve glycemic control in adults with type 2 diabetes. Empagliflozin, a component of Synjardy, Synjardy XR, Glyxambi, and Trijardy XR, is indicated to reduce the risk of cardiovascular death in adults with type 2 diabetes and established cardiovascular disease. In addition to its indication to reduce the risk of CV death in adults with type 2 diabetes and established cardiovascular disease, Jardiance is also indicated to reduce the risk of cardiovascular death plus hospitalization for heart failure in adults with heart failure with reduced ejection fraction. The US FDA has accepted our supplemental new drug application and granted priority review for Jardiance tablets for adults with heart failure independent of left ventricular ejection fraction. According to the FDA, a priority review designation is intended to direct overall attention and resources to the evaluation of applications for a treatment that, if approved, would be a significant improvement in the safety or effectiveness of treatments for serious conditions. The supplemental new drug application is based on results from our Emperor Preserved trial, which has the potential to establish empagliflozin as the first therapy to show statistically significant improvement in heart failure outcomes in adults with heart failure with preserved ejection fraction. You may recall that the FDA also granted breakthrough therapy designation back in September of 2021, which underscores the critical need for a clinically proven treatment for people with this highly prevalent, debilitating condition. We expect a decision from the FDA in the first quarter of this year, 2022. Jardiance is not indicated for heart failure in adults with heart failure with preserved ejection fraction. Jardiance is not recommended in patients with type 1 diabetes. It may increase the risk of diabetic ketoacidosis in those patients. Jardiance is not recommended for use to improve glycemic control in adults with type 2 diabetes with an eGFR less than 30. Jardiance is likely to be ineffective in this setting based upon its mechanism of action. Thank you for your time today. I'm happy to answer any questions you may have.
Thank you so very much. Next one is Nicole Earhart of UW Diabetes Institute.
Hello, good afternoon. Can you hear me? My name
Yep.
is Nicole Earhart, and I'm one of the adult endocrinologists at the Diabetes Institute. And I'm really excited to be here to talk about this important topic, which is making the weekly GLP-1 receptor agonist as preferred GLP-1 receptor agonists on the formulary. That includes semaglutide, 0.25 to 1 milligram, and hopefully 2 milligrams soon, and deglutide, 0.75 and up to 4.5. And so why is this so important? Well, I think you saw in our letter that we highlighted earlier and sent to you in the week about how important this topic is, because I had over 18 endocrinologists in just 24 hours sign on to these sentiments. So why do we want to use the weekly GLP-1 receptor agonist as our preferred GLP-1 agonist? Well, first to point out, we know there's a cardiac benefit to these medications. And right now, one of your GLP-1 receptor agonists that you have on the formulary does not have the cardiac indication. So that's Byetta or Bydureon, or excuse me, Byetta or exenatide, which you probably also know is a twice-a-day medication, but what you may not know, it also has to be timed to the meal. And so you have to time it 30 to 40 minutes before the meal to get the full effects, which is also very burdensome to the patient. So we would ask that exenatide be removed from the formulary and one of the weekly GLP-1 receptor agonists add as the preferred medication. Additionally, what we know is that the A1C lowering, the weight loss potential is greater for the weekly GLP-1 receptor agonist, which I also detail in the letter. And finally, I think this is less, this is a little less, this is less data, but truly what I see with my patients every day is that we also know that the American Diabetes Association tells us that we should use the GLP-1 receptor agonist as first line injectable, so over insulin now. And that came out in the guidelines from 2021. However, what I think is less tangible and people don't understand is that when I tell people you're going to be on an injectable, their face falls. They equate it with insulin, even if it's not insulin, and they feel like they've failed with their diabetes. You give them a weekly GLP-1 receptor agonist and you tell them it's going to cause them to lose weight, it's going to work great for their diabetes, and it's going to have heart benefit, and they're empowered to work on their diabetes, and we just see the results. And so I'll end with a story about a patient. So I just saw a patient last week who 6 months ago, we switched from liraglutide, which is Victoza, your other preferred GLP-1 receptor agonist on the formulary, to semaglutide. He's also was on metformin, but 160 units of insulin. 6 months later, he's lost 30 pounds. He's down to a cumulative dose of insulin of 40 units, and his goal is to lose 20 more pounds and get off of insulin. Now, this might be an exceptional case, but I see every day the benefit of the weekly GLP-1. So we would ask that semaglutide and deglutide be added to the formulary, preferred without prior authorization after metformin if clinically indicated. Thank you so much for your time.
Thank you. And last, we have Sarah Villarreal with Novo Nordisk.
Hi, can everyone hear me?
We can hear you. Go ahead.
Perfect. So my name is Sarah Villarreal, and on behalf of Novo Nordisk, I would like to provide a few updates on semaglutide injection, branded Ozempic, which, as mentioned earlier, is a once-weekly GLP-1 receptor agonist. It was approved by the FDA in December of 2017, and it is the most recently approved weekly GLP-1 receptor agonist. It's indicated as an adjunct to diet and exercise to improve glycemic control in adults with type 2 diabetes, and as of January 2020, it gained a new indication to reduce the risk of major adverse cardiovascular events in adults with type 2 diabetes and established cardiovascular disease. This places it in the elite class of GLP-1 agents recommended by the ADA for patients with type 2 diabetes at high cardiovascular risk, which typically consists of around 20% of the patients. This FDA decision was based on the combined data sets from the SUSTAIN-6 trial with Ozempic, which showed a 26% relative risk reduction in MACE events, and the PIONEER-6 trial with oral semaglutide, brand name Rybelsus, showing a similar reduction of 21%. Thus, adding Ozempic to join Victoza as a preferred formulary agent provides daily and weekly GLP-1 options, both with an indication to reduce cardiac events. In addition, we now have a new Ozempic pen containing 4 milligrams or 3 mLs, delivering a full month's dose in a single pen versus the previous 2 pen pack, each with 2 milligrams. Besides these new features, what has always made Ozempic stand out within the GLP-1 class is its efficacy in achieving glycemic targets as well as lowering body weight. In regards to efficacy in head-to-head trials, which were 30 to 56 weeks in duration, Ozempic 0.5 milligrams demonstrated A1C reductions from 1.2 to 1.5%, and Ozempic 1 milligram dose demonstrated A1C reductions from 1.4 to 1.8%. While not indicated for weight loss, weight effect was a secondary endpoint in the SUSTAIN clinical program. Mean weight loss of 7 to 10 pounds was noted with the 0.5 milligram dose of Ozempic, and mean weight loss of 10 to 14 pounds was seen with the 1 milligram. 2 head-to-head trials comparing Ozempic to other once-weekly GLP-1 agents have been published. SUSTAIN-3 compared Ozempic to Bydureon, and SUSTAIN-7 compared Ozempic to Trulicity. Both trials demonstrated that therapy with Ozempic resulted in greater A1C reductions, a greater percentage of patients achieving A1C targets, and a greater weight loss versus both comparators. GI side effects, including nausea, vomiting, diarrhea, abdominal pain, and constipation, are the most commonly reported adverse events with Ozempic. Similar to other long-acting GLP-1 receptor agonists, there is a box warning with Ozempic regarding potential risk of thyroid C-cell tumors, and as such, patients with a personal or family history of MTC and patients with MEN2 should not use Ozempic. For additional safety information, please refer to the package insert, and I would also like to thank you for your consideration, and I'll take any questions.
Thank you very much. Just checking to see if we have any other stakeholders, of which I don't see any. And we could then go to the motion.
Jordan, could we just clarify the preferred? Marissa, you had gone through the table pretty quickly. I had a hard time keeping up with the preferred versus non-preferred, and also the general rule. I know the generic names very well and the brand names less well. So if there's any chance we could include generics on this table, would be really helpful. But is there a once weekly GLP-1 agonist that is accessible? Just the data on these medications is so good. And having it accessible, I think, would be really helpful.
Hi, this is Marissa. So Leah, I will take that into consideration for the next PDL. Thank you for that feedback. So here's the GLP-1 agonist. It starts on line 40. We do not have a preferred once weekly product, but we did create a policy which actually just went into effect February 1st, which would require patients to step through either Byetta or Victoza. Those are our 2 preferred options right now, but of course we would review things on a case-by-case basis. If one of those agents is not appropriate for them, it could still be approvable if a once weekly is more appropriate for them, and that's based off of clinician discretion.
Okay, so it sounds like right now liraglutide is available as preferred. but would need prior auth for semaglutide or any of the once weekly dosing.
That's correct.
Okay.
Hi, this is Kavita Chawla here. So along these lines, are there any steps that we can take as the P&T committee to make semaglutide or dulaglutide as preferred agents because they have such overwhelmingly positive benefits for the patients without having to go through that barrier of a pre-auth process?
And I guess one additional question is, there was a really recent head-to-head trial of liraglutide and semaglutide, and semaglutide did have like pretty significant clinical benefits over liraglutide. And so I wonder if, and I don't think we've been able to review that study. And so I don't know if that evidence has been taken into consideration on the list yet.
This is Marissa. Hey, Donna, did you have any feedback on that? I think Kavita was wondering if the DUR board had any, sorry, Kavita, if you wanted to go ahead and repeat your question.
Sure. Yeah, Kavita here. Just wondering if we as the DUR board have an ability in the face of really compelling clinical efficacy evidence to propose either semaglutide or, well, actually semaglutide and dulaglutide, especially semaglutide as a preferred agent for the Apple PDL.
So this is Donna. So the recommendations, the motions that you make as the DUR board are recommendations. The reason why these drugs are not preferred is really the fact that they're so much more expensive than the daily product that we have not, made them preferred and wide open. We would love for manufacturers to sharpen their pencils and provide more meaningful discounts on these drugs so that they're more affordable for the program and sustainable to have them as open access. So at this time, I would not be inclined to add one because they are truly significantly more expensive. We're talking, and it's not just $50. It's several hundred to $1,000 more. I'd have to look at the actual costs to give you a relativity, and I don't have that information in front of me, but it is significant.
And Donna, this is probably an ignorant question on my part, but remind me, so if they're preferred status, they can be prescribed and received by the patient without prior authorization, is that correct?
In most cases, yes.
Okay.
So if it doesn't say prior auth required in column F, then they do not require prior authorization. Some drugs are in other classes, we've created them, we call them preferred, but we still require prior authorization to make sure they're being used as indicated, but not for these particular classes.
Thank you. And I see that column now. Sorry, I missed that, Marissa. You have that right there. And so liraglutide right now should be able to be prescribed without prior authorization.
That is Marissa. Yes, that's correct. That's Victoza for your reference.
This is John McKay. So if Bydureon is not available on the marketplace, would it be possible to at least make one weekly GLP-1 available, change the Bydureon B size to preferred?
Yeah, that's the one that's really expensive.
Oh, B size. I mean, that's not my preferred agent go-to, but I feel like in terms of adherence issues that we need at least one weekly.
Yeah, they're all crazy expensive compared to daily doses.
This is Diane Schwilke. I would not advocate for that one because it's the one of the three that doesn't have any cardiovascular benefit proven, and yeah, it would need to be one of the others if we were going to kind of require some sort of weekly, either Trulicity or Ozempic. and Ozempic definitely head-to-head with Trulicity most recently saw we had better weight loss as well as A1C reduction.
This is Laura Bessie. So just for an education standpoint, how long do they have to be on the daily agent prior to failing that therapy? I mean, is there a 3-month window? What is the expected trial period? Or is that documented somewhere?
Yeah, this is Marissa. So per our GLP-1 policy, the trial would be 90 days, so 3 months.
Okay.
Kavita here. Marissa, would you please remind us, so what is the definition of failure? Is it lack of A1C improvement? Is it intolerance, or is it also non-adherence for the patient?
This is Marissa. I don't know if in the policy, sorry, I'm trying to reference it. I believe it would just be like no clinical benefit. So it would probably be no reduction in A1C. Actually, here we have it. History of failure is defined as the inability to achieve glycemic control, intolerance, or contraindication, or clinically inappropriate to that particular tried agent.
Are we
Kavita,
able to make, oh, go ahead, sorry, Kavita.
No, I was sorry. I was because there's such major overlap between diabetes and obesity. I cannot remember whether there's a separate class of obesity management drugs that we would review at a separate time, and maybe I'm just thinking of like failure to improve. In my mind, also often includes the weight component, since metabolic syndrome is all of the above. So I guess the question is there a different class of anti-obesity medications that we would be reviewing at some point later this year where this could be brought up for discussion again?
Yeah, so Kavita, this is Marissa. We actually don't cover any weight loss medications for the Apple Health program. So those products, I don't believe they're actually even included on our PDL, but we don't cover any weight loss medications for Apple Health. So it wouldn't be reviewed at any DUR board meeting.
Sorry. Is there a way that we could make a recommendation that, pending more cost-effective options, we think that the once weekly dosing of the GLP-1 agonists are compelling from a clinical standpoint or a clinical outcome standpoint, and pending, some reduction in cost, we would strongly recommend that they be added and that be reviewed at some point. I don't know if there's any wording there that we can at least signal that these medications are really effective while understanding the cost implications.
You can add that if you want to the motion. I mean, obviously, if the cost comes down and they get closer in price, we would definitely want to add it. This is kind of our leverage to be able to get manufacturer rebates is through the PDL. So that's kind of the challenge that we have to face. Okay, we only have 5 minutes left in the scheduled meeting, so are you ready to make a motion?
I just want to ask this, Laura Bestie. I want to ask one more question. Is there any way that they can add restrictions to them for patients that have a high cardiovascular risk so that you could restrict them and use them first line for patients that have that high cardiovascular risk that would definitely benefit from that over the other agents?
And hi, Laura, this is Donna. Yeah, I mean, we can look into something like that. We've done that in the past for Ramipril back when Ramipril was expensive. But yeah, we can take that away and try to see if we can come up with some.
Because it just seems like there's a real benefit for this class of medications for a certain part of the patient population that would significantly benefit. So some of the patients might be okay with the once daily, especially if there's the significant cost difference. But for those patients that have that high cardiovascular risk, this would certainly be the preferred agent over the preferred ones that are on the formulary currently. So if they could have them maybe restricted, I don't know if that's an option, but that might be a way to at least make it a little more preferable as an option.
A couple of things, I guess. This is John Stark on the motion. I don't see anything in our motion that necessarily would require there to be 2 preferred products of each drug class, or as it's maybe defined, a sub-drug class. And it seems like, well, I mean, technically, I think right now we could have like 2 types of insulins, and we'd meet the way that it's written right now. So I wonder if that should be included somewhere.
Hi, this is Marissa. So Jordan, sorry, was there something you would like me to add to the motion?
Trying to figure out my language for that. So there should be 2 preferred drugs from each anti-diabetic subclass.
Hi, Jordan, this is Donna. Are you trying to say you want 2 preferred drugs from each drug class, or are you commenting on that you must try and fail 2 preferreds within a drug class?
No, my comment was not necessarily for that one. My comment with that was, you know, we just, right now it's such a huge class, and I would want to make sure that GLP-1 agonist, actually there is a preferred GLP-1 agonist, and there is a preferred SGLT2 inhibitor. And I don't think we have anything right now that says that.
Okay, so you want to say something like there should be at least 1 preferred drug within each subclass of anti-diabetics.
And I would also want it to include with cardiovascular benefit, because not all within each subclass have that. So if it's an option, I would want that to be preferred. This is Diane Schwilke, sorry.
And I would, this is Donna, I would push back a little bit on that. We can make it preferred, but it would still be on prior authorization, which basically means it's still non-preferred. If we're only going to limit the weekly medications to, you know, those with high cardiac risk. So if you want to say, you know, make drugs with cardiac benefit available to those at high cardiac risk or something of that nature.
Well, I think you could argue that any, especially poorly controlled diabetic, is inherently going to have cardiac risk.
Right.
Kavita here. I guess the way I'm reading this right now, all non-preferred products require a trial of at least one preferred product in each anti-diabetic subclass.
Marissa, are you typing? I think you're changing the wrong part.
Hi, this is Marissa. Yeah, I was trying to wordsmith it. If you want me to, if you guys wanted me to go to the part that you want me to correct, just let me know. I was trying to type and listen at the same time.
Undo all the changes you just made. Okay, and then before this sentence, add a new sentence that say at least one. There must be at least one preferred agent in each anti-diabetic subclass.
There must be at least one preferred product in each anti-diabetic subclass?
Yeah.
Okay, thanks.
And then leave the last sentence the same.
Okay.
Now with just Kavita here, anti-diabetic subclass, comma, with proven cardiovascular benefit when applicable. Because there are two classes here where there are agents that have proven cardiovascular benefit versus not, or proven nephroprotective benefits versus not. So I don't know how detailed we want to get in here, but like the class example here being Xanatide is not really useful to have it as the only preferred. So it's good that we have liraglutide, but we want to make sure we retain that.
This is Susan Plata, but do we need to get that detailed when the ordering provider probably knows his patient, and I would think, would order the cardiovascular drug he would want for his patient? I don't know. I just feel like we're going to get too detailed in this. I think it sounds good how it is. I mean, how much direction do we really want to make the provider? Isn't there some like provider discretion?
Kavita here, I thought that this is more for us as HCA, or this is more a direction for HCA to make sure that they are including a preferred medication in each drug class. It's not for the provider, but it's for HCA's, not HCA, sorry, DUR and Apple PDL to include at least one medication as preferred. Am I understanding that correctly?
I think the concern that Kavita is trying to talk about is if, for instance, they weren't able to get as good of a price on Victoza, and so that fell off of the PDL, then we would not have a GLP-1 agonist with cardiac proven benefit. And we want to make sure that there is one of the GLP-1 class that has that cardiac benefit.
Hi, this is Marissa. Sorry, Kavita, can you repeat what you said? I didn't document it. I apologize.
Kavita here, yeah. So just after subclass, comma, with proven cardiovascular and nephroprotective benefit where applicable.
And I think, I would like to go back then and look at the quality of the evidence on these. If we're going to give to this level of detail in deciding what makes something preferred, because some of these are not. I mean, the cardiovascular is a primary outcome. I'm not familiar with the data on the nephroprotective, so I'm cautious to try to say we have to go find something that's nephroprotective if there's not, strong evidence supporting its use, but it's something that's being advertised as,
Kavita here,
a drug.
Yeah, and then I think this is why KDIGO included SGLT2 inhibitors as first line, because of that very reason of SGLT2 inhibitors, specifically the dapagliflozin and empagliflozin, having those nephroprotective benefits that were majorly clinically significant. So more than advertising, it's also the national guidelines that are strongly recommending these. That was prompting me to include them here.
And again, then I would still want to go back and look at the evidence and potentially have, you know, DURP look at the evidence on these and get a good grading for it before we have the nephroprotective language in here.
Donna, do you have a suggestion for how to kind of move forward with this? Because I think what I'm kind of hearing is the committee has, you know, we've been educated, I guess, about this benefit, and yet we haven't had it. Or I think also we had some of our presenters today kind of bring up this, and yet I think there's some concern is that when are we going to feel this again, and do we have a way of moving this forward?
I mean, you can make the recommendation if you want. We'll move forward with the cost analysis as we typically do.
So this is Laura Bestie. Can I ask one more clarifying question? So the next sentence says that they require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized. So does that mean that if they're on a GLP-2, they have a GLP-1, they need to do 3 months of one product, 3 months of another before they can go to a non-preferred agent? Is that correct? So we'd need to fail 6 months of a preferred.
This is Marissa. So the way that we have it written in the policy is that they can be used separately or simultaneously with different agents for a minimum of 90 days. So if they were taking metformin and like an SGLT2 inhibitor at the same time, it would just have to be 90 days for both of those. So they could be taking, you know, typically in diabetes, you'll see patients on metformin, and I'm just saying like insulin, and then possibly, you know, other agents as well, all at the same time. So if we see that there's simultaneous use of those, then we would qualify that, you know, at least for 90 days as a trial. It doesn't have to be
in the same class.
Yeah, it doesn't have to be separate, 90 of this, 90 of this, 90 of this, like all at different times.
Okay.
But I think Marissa, we're specifically, I think she's kind of talking about GLP-1s, is that all physicians, I think, are going to prescribe Victoza first because it has the known cardiac benefit. You would need to try that for 90 days. You find that it fails if you're not able to get your control there, at which point then you would need to move to Byetta, do 90 days of that to say that that failed, at which point then you'd be able to try a different GLP-1.
So specifically, sorry, this is Marissa, for our GLP-1 policy, we do lay out that it's really just metformin, 1 preferred SGLT2, and 1 preferred GLP-1. So it could be either Byetta or Victoza, but we do require also an SGLT2 inhibitor trial and failure, as well as metformin. So it would be all 3 of those. And it doesn't, you know, they could pick either Byetta or Victoza in reference to the GLP-1s. They don't have to try both, but as long as there's history of one of those on top of the other 2 agents that we laid out.
I guess I'll move forward. I move that all products in the drug classes listed on slides 7 and 8 are considered safe and efficacious for their medically accepted indications and are eligible for preferred status and grandfathering at the discretion of HCA. Products in this class may require prior authorization to determine medical necessity. There must be at least 1 preferred product in each anti-diabetic subclass with proven cardiovascular and nephroprotective benefit if applicable. All non-preferred products require a trial of at least 2 preferred products with the same indication before a non-preferred drug will be authorized unless contraindicated, not clinically appropriate, or only 1 product is preferred.
This is Leah Marcotte. I second that motion.
All in favor, please say aye.
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 Any opposed? All right. That gets for that one. Do you guys want us to do the last set of agents tonight? Move on to Iman again.
Hi, Jordan. This is Donna. We can go ahead and move that class to the next meeting or review it at a different time.
Okay. Well, with that, then it was a little bit of a change, but it looks like our business for today is done, and we can adjourn. Thank you.
Thanks, Jordan. Thank you.
Thank you all. Thank you, Jordan.
Thank you, everybody.
Good evening.